My name is Louise Lacey. I hope you all recognise my name, if not my face, from the Values in Action here in CH East and most recently the Bray Staff Health and Wellbeing Committee. So I'd like to welcome you all here today to the second CH East Health and Wellbeing webinar. Today's webinar will focus on the menopause and our mental health. Health and Wellbeing staff here in CH East are one way or another helping people through webinars to delve into their own health and wellbeing and their mental health. I'm delighted to be here with Dr. Genevieve Ferraris from the Menopause Hub, and the purpose of today's webinar is to learn about the menopause and how it affects your mental health. By supporting your own mental health through the menopause, we encourage participation questions throughout the webinar, and it will be recorded and the link available for sharing with your colleagues. So following today's webinar, we plan to focus on specific areas of health and wellbeing. So if there's any area that you wish to be discussed through webinars, please do provide feedback. So thank you for your attendance, and I'll hand it over to Dr. Ferraris.
Perfect. Thank you, Louise. Thank you everyone for attending today. I'm glad I still have a voice because there was lots of shouting this weekend with the rugby. Today, as Louise mentioned, we're going to be talking about menopause and mental health. I'm just going to bring up my slides. Perfect. So just quickly about me, I'm a GP. I have a special interest in women's health, but I work primarily in menopause at the Menopause Hub in Dublin. And we've just recently opened our third branch, which is in Cork. And it's perfect timing because this week is International Menopause Day. And perfect timing for this talk as well because last week was Mental Health Awareness Week. So really quite a nice intersection of two very topical subjects at the moment. And I think subjects that have both been subject to a lot of stigma in the past, people have not been comfortable speaking about either menopause or mental health. So I think this is a really useful kind of jumping off point for people to look at those things. So just quickly, kind of an overview of the presentation today. We'll go through some definitions, back to school for a bit with a little bit of biology and hormones, and then we'll go through symptoms, especially symptoms that can impact mental health, implications at work, and then management and treatment options. So just quickly to go through some definitions. Menopause is the complete cessation of periods for at least 12 months, and for most women that happens at around 51. So that means that periods stop at 50, by 51 should be considered in menopause. Can happen a little bit earlier, kind of between 45 and 51 would be quite normal, and some women do still get their periods beyond 51, and that can be normal as well. Perimenopause is the lead up to menopause, so it starts for most women around 45. Their periods start to change, hormones start to fluctuate. They do definitely get symptoms around that time as well, and then eventually when periods stop, that's when we call it menopause. You get perimenopause, menopause, and then postmenopause is about 7 years after the onset of menopause. At postmenopause, you're still not ovulating, you're not having periods, but you are not no longer symptomatic when you're postmenopausal. In terms of mental health, it's very much, when we talk about mental health, we think about the kind of psychological impacts that something may be having on our health, but I think mental health is also brain health, and so today I will be looking at how menopause impacts brain functioning and not just mood. And then reproductive depression is something which we'll discuss a bit later, but this is really depression which is linked to hormones, so postnatal depression, PMS or PMDD, which is premenstrual dysphoric disorder, and depression in menopause, all fall under the category of reproductive depression, which is really a depression where hormones are a possible cause or a likely cause. So, doing a little bit of biology. In terms of the menstrual cycle, for most women, they have a 28-day cycle. Some women it's a bit shorter, some women it's a bit longer. But with the premenopausal menstrual cycle, the cycle begins on day 1, which is the last day of our periods. The lining of the uterus is thin, and estrogen then starts to build up as the follicle prepares to be released. And then day 14, the follicle is released, we ovulate, there's a rise in estrogen, there's a rise in FSH, which is the follicle stimulating hormone. That follicle then becomes the corpus luteum, which will become the placenta if there's implantation, and that releases progesterone. So the first half of the cycle is dominated by a rise in estrogen. The second half of the cycle is dominated by a rise in progesterone. With that rise in progesterone, the lining of the uterus thickens, and then by day 28, if there's no implantation, we have a bleed. So this is important when we start going into perimenopause, because it explains some of the symptoms that we get. So in perimenopause, we're born with a finite number of eggs within our ovaries, and when we go into perimenopause, it's coming up to the end of that number of eggs. We're reaching the end of our ovarian reserve, and so ovulation starts to become erratic. So we may not be ovulating every month, and so that means that the lining of the uterus may build up over 2 months, and that's when we start to see really heavy periods in perimenopause. Or we don't ovulate and we have really short cycles. So that explains why we start to see these changes in periods as one of the first things that happens in perimenopause. When we get to menopause, we've reached the end of our ovarian reserve. So the ovaries no longer have any eggs, nothing's being released, we're not building up any endometrium, so we're not having periods, but we're also not building up estrogen and progesterone levels. So then it's the loss in those hormones which then gives us symptoms as well. So in perimenopause, it's the fluctuation in hormones. In menopause, it's the decline in hormones. Interestingly, on the slide, you can see that around ovulation time, there's a peak in FSH. So FSH is follicle stimulating hormone, which is released from the brain, sends a signal to the ovaries to say, okay, the egg should be released now. When the ovaries are running out of eggs, the brain keeps releasing FSH, and so it rises in menopause. And that's why we use it as a marker of menopause. In terms of testing for menopause, this is something people ask. We don't need to be testing a woman who's 45 and above who stops her periods. We know she's in menopause. But if, for example, we had a younger patient in her early 40s, late 30s, whose periods had stopped, and we were concerned she was in early menopause, we could use the FSH as a marker to test for that. This slide really is just similar to what we were talking about earlier, which shows the gradual decline in hormones through perimenopause and menopause. Testosterone is not on the slide, but I thought I'd touch on it because it's something which gets a lot of kind of press at the moment. Women do make testosterone in our ovaries and our adrenal glands. It seems to decline the sharpest between our 20s and 40s, and then reaches a new plateau in our 40s. So it's not a hormone which drops in menopause, but some women may be symptomatic of lower testosterone in their menopause, and that's why we use it. So, on to the symptoms. When we think of menopause, or traditionally when people thought of menopause, it's hot flashes, periods stop, and that's about it. But really, there are over 40 recognized symptoms, and they can be very widespread, including physical symptoms, mental and emotional symptoms, and genitourinary symptoms. So it's really helpful using a symptom checker like this. This is from our website, but it helps to kind of gauge what symptoms you're experiencing, to what degree you're experiencing them. It helps to give an overview of where you're at currently, and it's something which you could take with you when you go and have a chat with your doctor about what you're experiencing. Today, we're really going to be looking at the mental and emotional symptoms, although some of the physical symptoms do come into that, so I'll go through them. So the 3 areas that I want to touch on in terms of menopause and mental health is mood, sleep, and brain fog. So looking at mood, there are a huge number of mood changes that happen around this time. And A, it has to do with the changes in hormones, but B, it also has to do with the impact of the physical symptoms. Because if you are not sleeping and you're having hot flashes and you're not feeling comfortable in your body, that will obviously have an impact on your mood. But then there's changes in your serotonin levels and your cortisol levels, which all impact mood as well. So the mood changes can be very widespread. Low mood is something the patients complain about a lot. So it's not necessarily feeling depressed, but they'll say to me, I feel really flat. I'm not really interested in things. I don't want to do much. I don't feel overly happy. I don't feel really sad. Kind of very flat range of emotion. It can definitely progress to depression, and some women feel, especially if they've had a previous history of postnatal depression, if they've had a history of a major depressive disorder in the past, they may be more prone to depression in their menopause, which is something to be mindful of. Mood swings are also really common, and especially because PMS seems to get worse around the perimenopause. So we've all been there. We all know that before your period, you want to cry and you want to shout and you want to eat all the chocolate. So it really seems to heighten before a period in perimenopause. So those mood swings can be quite dramatic. Patients will say to me, No one wants to be around me. I don't want to be around my family. Everyone annoys me. If I could kill my husband, I would. So, really a lot of rage and irritability which comes in. And then tearfulness as well. Watching an ad on the TV, there's a puppy and you burst into tears. So I think a lot of women can relate to these symptoms. It's just about kind of exacerbating the symptoms around perimenopause especially. Anxiety is also something which some women may experience for the first time in perimenopause. So anxiety really being a state of fear or nervousness with a lot of physical symptoms associated with it. So palpitations, shortness of breath, feeling kind of tingling in your hands and your face. If you are really anxious, some women may experience panic attacks for the first time. And it can be really new onset anxiety. I've had patients say to me, I've been a confident driver all my life, and now I'm too scared to drive in the car with someone. So it feels really irrational, and there's no good reason for it. And interestingly, progesterone is a really nice calming hormone. So when we start to get these fluctuations in progesterone, it seems to be that's where the anxiety comes in. Loss of confidence, I think, is multifactorial. Part of it has to do with the changes in mood. Part of it has to do with the physical symptoms. But for many women, they're at a time in their lives where they are at a good point in their career and they're kind of settled in their family lives, and they should be feeling the most confident they've ever felt. And a lot of them say to me, I've lost that confidence. I don't feel like myself anymore. That's something that I hear a lot. And these are symptoms which, for me, are really important to address because they can make a woman's menopause transition good or bad. And if she's having a lot of mood symptoms and really struggling, she's going to have a really difficult time in her menopause. So it's so important that we address these mental health symptoms. Alongside mood changes are sleep changes. And for many of my patients, when they start their perimenopause, it's changes in periods, changes in mood, and changes in sleep. Those are the first things that we see. And the sleep issues can continue throughout their menopause transition. The typical kind of insomnia that we see would be middle to terminal insomnia. So they would say, I'm so exhausted, I get into bed, my head hits the pillow, and then 3 to 4 hours later, wake up, mind is racing, heart is racing, I can't fall back asleep, I'm awake for hours, I feel exhausted, or kind of waking up towards the end of their sleep cycle, not really time to get out of bed, finally fall back asleep, the alarm goes off 5 minutes later and it's kind of ready for the day and you feel exhausted. So that, we know how important sleep is and for functioning and mood and cognition. So when you're not getting sleep, of course it will impact your mental health. Other things that can further worsen or impact your sleep would be night sweats. If you're getting up every few hours to change your night clothes or because you're wet or uncomfortable or hot, that will definitely impact your sleep. Genitourinary symptoms, so if you're needing to get up tonight to wee 3-4 times as well, again, that's broken sleep. Then you kind of get back into bed feeling uncomfortable, feeling anxious, sleep is disturbed. And, anxiety generally patients who are anxious have sleep difficulties because the anxiety ramps up at night. So that, again, has an impact on sleep. So it's very multifactorial. Brain fog is something that I wanted to talk about because actually it was the topic of last year's International Menopause Society, the International Menopause Day. Their topic was brain fog because it's a symptom which is extremely concerning for a lot of women because all of a sudden they can't remember names, they lose their train of thought, and they think they're going into early dementia or early Alzheimer's. They possibly have a loved one who's experienced it, and they really are so scared that that could be happening to them. So I think just acknowledging that brain fog is a common symptom. It's not early dementia. It will improve when you get into postmenopause. Just knowing that can be really reassuring. But in terms of what brain fog is, because it's a very kind of generalized term and it's used for a lot of other things, it's not specific to menopause. You might hear it used as part of long COVID, for autoimmune disorders, for ADHD, people will talk about brain fog. But really it's cognitive symptoms which tend to manifest in memory and attention difficulties. The big issue with memory seems to be verbal. So patients or people will say they don't remember the words and names of things. So I'm looking at someone, I know their name, I've known them all my life, but I can't get their name out. Or I'm in a presentation, I'm discussing a topic that I know really well, I can't think of that word, I'm talking around it, I'm getting myself flustered, the word is completely lost, and it can be really kind of an embarrassing symptom, a frustrating symptom, and you leave the meeting and the word goes into your head. But other things can be kind of maintaining a train of thought, so doing your work and then you get really distracted. I think we live in an age of distractibility with our phones, so sometimes it can be difficult to disentangle. Is this brain fog? Is it just my life? But if it's happening on an ongoing basis, there probably is some degree of brain fog. Also, possibly difficulty completing tasks, going up the stairs to get a pair of jeans, and you get up the stairs and you can't remember why you've gotten there. I think we've all done that. So really, brain fog is just an exacerbation of things that we've probably done before and possibly getting to a point where it's having an impact in your life. Things that exacerbate risk factors for brain fog would be low level of education. If you're in poor physical health, there's a genetic vulnerability, and life stresses as well. So people who have stressful life circumstances tend to be more at risk of brain fog. But then alongside that, why does it happen in menopause? It's the changes in estrogen. It has an impact on our hippocampus, which is our memory area of the brain, and our prefrontal cortex, which is the processing part of the brain. But also low mood has an impact on cognition, poor sleep has an impact on cognition, and interestingly, women who have bad vasomotor symptoms, which are the hot flashes and night sweats, tend to have worse brain fog as well. So if we can look at addressing those symptoms for women, often the brain fog improves. So really, menopause is a difficult time for women for their mental health, because not only do we have the mood symptoms of menopause, we've got the physical symptoms as well, as I mentioned. So you're having hot flashes and night sweats, you're not sleeping, you might be achy and sore, you might have gained weight and you feel uncomfortable in your body, your hair is changing. There are a lot of things happening to your body that may impact your body image, how you feel about yourself. And then on top of all of that, it tends to be a really stressful time in a woman's life, because she may be caring for elderly parents or relatives on one side, young kids on the other side. She's working, probably a full-time job. So she's being pulled in a lot of different directions, and at the same time, kind of feeling like a teenager with out-of-control hormones. Although puberty and menopause are not the same at all, if we think of when we go into puberty, all these changes in our hormones and how we felt, coming to perimenopause, it's again loads of changes in hormones and can make us feel really out of control. I think sometimes patients will say, well, what if it's not menopause? What if it's just that I'm under a lot of stress and life is busy and this is just me? And I think it's important to then think, well, what impact are these symptoms having on me and on my life? Am I anxious and irritable more often than normal? Am I sad more often than normal? And is this impacting my ability to do things and to form relationships and to engage in things that I would normally enjoy doing? Does it impact my work? Does it impact my sleep? And if you find that, okay, I'm a bit stressed, but I can still function as I normally would, it's possibly something which is circumstantial and will improve. But if you find the impact is extending beyond just how you feel, it's having an impact on relationships and how you take care of yourself, then there's probably something more going on. And then we need to think, is this depression? Is this menopause? Is it both? And how do we address it? Differentiating between the depression that happens in menopause versus clinical depression or a major depressive disorder, there are some changes, because again, patients might come and say, I feel really low, am I depressed? It's also at the same time that I'm in menopause, how do we know? And generally the mood changes that happen in perimenopause and menopause are quite fluctuating. So you may have some good days, some bad days, whereas in depression it tends to be more ongoing. So it's a continuous state of feeling low and sad. And in menopause, there's more irritability and anger as opposed to in clinical depression. Interestingly, in menopause, we see a lot of intrusive thoughts. So that can be really concerning for patients, because all of a sudden a thought pops into your head that you may have never had before. I wonder what would happen if I drove my car into a wall. And it doesn't mean that you're going to do it, but suddenly the thought is there that you may not have had before. And just that thought itself can be quite distressing. Generally, patients don't act on them, and intrusive thoughts are actually extremely normal. We all have them. It's just being aware of how they impact you, I suppose. But those tend to be more in menopause, which is interesting. If you think of those symptoms that I've listed now, and that's not extensive, so mood symptoms, sleep symptoms, brain symptoms, of course that's going to have an impact on work and functioning. Some patients will say, I can hold it together at work, I put all my energy into holding myself together at work, and at home I fall apart. But some patients may feel that they can't, keep it together at work. The symptoms may make them feel that they can't do their work anymore. They're not confident in their ability, they've got the brain fog, they've got a low mood, and they don't want to keep working. And it would be a huge loss to the workforce if these women were leaving work at that time, because many of them, as I said earlier, are really advanced in their careers, they have great value to offer, but suddenly because of their symptoms, they're questioning their ability to work. And so I think it's really a time when business owners and employers and people, working in mental health at work need to be mindful of the impact that menopause is having on work and making sure that women are cared for and supported and that we're not losing these women from the workforce. This the slide, unfortunately, is not very clear, but it was a study done by the Menopause Hub looking at kind of how patients, women, felt that their menopause impacted their work. And a jarring finding for me was that over 50% of women would consider leaving their jobs because of the symptoms they were experiencing. So we've gone through changes in menopause and the symptoms, which is great, but now we need to understand how can we look at addressing that, how can we treat it. And the treatment is really multimodal, and I think we need to look at what can we do ourselves, and then what treatments can be offered medically, non-medically, to improve the symptoms and to make the menopause transition much easier for women. So the first thing I always look at is lifestyle, because this is not just important for mental health, it's really important for general health. And menopause is a time in our lives when we are getting older, and there are certain things like cardiovascular disease which increases in women who are postmenopausal. So by addressing our lifestyle, it's not just looking at how we can improve our mental health, how do we improve cardiovascular health, bone health, and so on. It's boring, it's stuff we know, it's often the first thing that we stop doing, but things like exercise, the guidelines for exercise vary. For cardiovascular benefit, it would be 150 minutes of zone 2 cardiovascular exercise. So that's, a fast enough walk where you probably can't maintain a conversation, but you're not so out of breath and panting and you feel exhausted after your exercise. I always say the best exercise for you is the one that you can maintain. So if you love doing Zumba, do Zumba. If you love swimming, do that. It has to be something which you enjoy and that you get benefit out of, because that, the mental health impact of exercise is huge. It's greatly beneficial. I understand that sometimes doing these lifestyle things can be extremely difficult when your mental health is poor, and sometimes just getting out of bed can be really difficult. So then to say, oh, well, you should go for a run can feel a bit tone deaf when you are feeling really low. But if you could start to make small changes around these things, it could make a big difference. And we build those things up over time. So if it's getting out of bed for a week and then stepping out of the front door for a week and then going around the block and just gradually build it up, that can be really helpful. Maintaining a healthy BMI is important as well. Again, not just from a mental health perspective, but a general health as well. It seems probably in menopause that the best kind of diet is a Mediterranean type diet, which sadly I always say is not bread and pasta and wine. It's lots of vegetables and lean proteins and whole grain carbohydrates and pulses and fruits, and really limiting our intake of refined and processed carbohydrates and glucose and those, the things that are delicious. Still eat them, just eat less of them. Stop smoking, we know. Reduce alcohol intake, we know. Alcohol, it has a depressant action on our CNS. So really, if your mood is low, it will make you feel worse. If you're anxious, it will make you feel worse. The ones on the right-hand side of the slide, so mindfulness, connection, managing stress, I think those are helpful things that we can do ourselves when we're in stressful situations. So managing stress is not necessarily reducing stress, because for some patients or people, it's not an option to say, oh, well, I'm working too much, let me cut down on my hours, or I'm too busy at home, let me get someone to help me. Financially, that can be impossible. So, okay, this is the level of stress that I have in my life. How can I look at managing that? And two things that are really helpful is breathing. So when we're in a stressful situation, we tend to hyperventilate. We breathe a bit faster, we breathe shallower, and that's kind of a primitive signal to the brain to say there's something bad happening, we're being chased by a tiger, there's a whole load of cortisol which comes in, and that fuels our anxiety. So if we can slow down our breathing, it's kind of calming to the nervous system. Okay, we're safe, there's no tiger, and the cortisol levels drop. A really nice way that I like to use is box breathing. So you breathe in for the count of 5, hold for the count of 5, out for the count of 5, and hold for a count of 5. And if you can do 5 of, sitting at your desk, you're feeling frantic and overwhelmed, 2 minutes, do your box breathing. It really helps to kind of calm your nervous system, and then you can move on with your tasks. Something else which is shown really helpful for stress management is cold exposure. And I had no idea about cold water swimming until I moved to Ireland. And it's people, and women particularly, seem to really love it here. And there's great evidence, because exposure to cold is a stress on the body. And if you can expose yourself to cold on an ongoing basis, when you're exposed to other stresses, your body goes, oh, we're kind of used to stress, we can deal with this, and you don't get such a huge flood of stress hormones coming in, which is really interesting. So now's the time to take up cold water swimming going into winter. Mindfulness and self-compassion is also something which is really important, because I think women especially tend to really berate ourselves when we're not doing all the things we think we should be doing. And we've heard it so many times before. How would you speak to a friend? And is that the way you'd speak to yourself? We look in the mirror and say, oh, I don't like how I look today. Look at my hair. I feel overweight. I feel frumpy. Or I can't get everything done. Look at her. She's doing work and kids and socializing and she looks fab. Why can't I do that? And I think, to turn a lens of kindness onto ourselves and just realize that we're doing the best we can where we're at, and to speak to ourselves as we would a good friend can often be a really kind thing to do to ourselves. Mindfulness is about being kind of present and aware of what's going on around you. So when you're in that phase of spiraling thoughts, take a step back and think, okay, what can I see? Name 5 things that I can see, 4 things I can hear, 3 things I can smell. And that kind of takes the significance of the thought away a little bit and helps you to be more present and mindful of what's going on around you. And again, really helpful for stress management. Train your brain, and staying connected, that's really important for brain fog. So we find that social connections help to prevent dementia, or it's one of the things that people use in dementia prevention, but really just staying socially connected at a time when women often want to withdraw. They're not feeling good about themselves, their mood is not good, we tend to isolate ourselves. Really, it's an important time to try and connect with friends, family. Training your brain, that's crosswords and Wordle and the things that we all can have on our phones, and it's quite a good thing. Instead of scrolling Instagram for 5 minutes, maybe do a mini crossword. Part of menopause and the treatment of menopause is HRT. And HRT was controversial for many years. There was a study released 20 years ago by the Women's Health Initiative. The findings were misinterpreted and kind of relayed to the public in a very alarming way. And women were basically told that if they took HRT, they would get breast cancer. And we have a huge amount of data that's been done since. We have newer types of HRT. We know now how safe HRT is, but for many women for many years were very reluctant to take HRT because of the perceived fear. We know now that HRT is the most effective way to treat the symptoms of menopause. So the mood symptoms related to menopause, if a woman can't take HRT, she'll derive great benefit because it'll really improve her mood. The breast cancer risk still exists with HRT, but it's much, much lower than what was previously believed. And for many women, the benefit that they get from HRT in terms of the symptom relief and the improved quality of life really outweighs that very small risk. HRT, the main hormone that forms part of HRT is estrogen, because it's the loss of estrogen, which we saw in the slides earlier, that contributes to many of the symptoms of menopause, whether they are mood symptoms or physical symptoms. But for women who still have a uterus, we have to give them progesterone as well, because estrogen, as we saw in the slide, builds up the lining of the uterus. Progesterone stops that from happening. It protects the uterus, but it also has a really nice calming effect. It helps with sleep, it helps with anxiety, so we get additional mood benefit with progesterone as well. Testosterone is sometimes referred to as the missing hormone or the third link. It can be really helpful for some women. The primary indication for using it is for low libido. I didn't talk about that. It is obviously a mental health symptom as well, but it's very multifactorial. And generally in women, if we can improve their symptoms with estrogen and progesterone, libido will improve. If it doesn't, we've got testosterone, which we can use as well. Some women may choose not to use HRT. They may not be able to use HRT. So, for example, a woman who's had breast cancer may not be able to use HRT. And so there are non-hormonal alternatives that we need to consider. I'm sorry, this picture actually hasn't come out very well. That's my lady doing her cold water swimming. So non-hormonal medications, those are medications that would address kind of the mood and sleep symptoms of menopause. So those would be our antidepressant medications. SSRIs, which are selective serotonin reuptake inhibitors, or SNRIs, which are selective norepinephrine. So they just work on different receptors. Some women are they've had a poor experience where they've gone to see their healthcare provider with their symptoms of menopause, and they've been told that they should start on an antidepressant. And while that's not necessarily wrong, because an antidepressant can be very helpful in managing mood and anxiety symptoms, in the setting of menopause, if there's no contraindication, HRT would be the first-line option for managing her mood symptoms. And an SSRI can definitely be added on if her mood symptoms persist. And interestingly, HRT and SSRIs work really well together to manage mood if need be. The other medication that's on there is gabapentin, which is a medication used for epilepsy, for chronic pain, as a mood stabilizer. So again, for our patients who can't take HRT, who are not maybe responding to the SSRI, gabapentin is really helpful because it also works on the vasomotor symptoms. It helps with flushes and night sweats. Looking at things that have nothing to do with medication but are still considered kind of medical treatments, that would be therapy. So whether that's CBT, cognitive behavioral therapy, psychotherapy, counseling, that can be incredibly beneficial as well. It can be difficult to access. I know we have limited providers for these things, and there's, I think, a huge demand on the mental health services post-COVID. But CBT, which is cognitive behavioral therapy, has really good evidence for managing symptoms of menopause, not just mood symptoms, but the hot flushes as well, which is interesting. And cognitive behavioral therapy is not the traditional sitting down, talking to a therapist about your childhood or what happened in your day-to-day. It's more about kind of reframing your thoughts around events and learning coping skills. So it's very beneficial in a treatment modality that you can then use for the rest of your life. Counseling and psychotherapy is more the kind of talk therapy, which can be helpful as well, but we've got really good evidence for the CBT. Complementary alternative treatments, those are things that I get asked about a lot. So that would be supplements, herbs, acupuncture. There is not a huge amount of data for them. It doesn't necessarily mean that they don't work. They just haven't been studied extensively. There are things like St. John's wort, which some people may use for mood. It tends to interact with a lot of medications. It definitely can't be taken alongside HRT, which is why we would not recommend it. Herbs like black cohosh and sage, which is used for flushes, can be beneficial, but because there are no long-term studies and it's still something being metabolized by the liver, we would need to be mindful of using those long-term. Something like acupuncture, some women find great benefit from doing acupuncture. There's very little harm, so it would be safe to add on if you wanted to. So really, I think it's important with all of this is to see there are lots of options. Every woman is different. Her needs are different. Her treatment plan will be different. And it's about, coming up with a plan with a suitable healthcare provider to manage the symptoms as effectively as you can through your menopause transition. Just importantly, not every woman will experience symptoms in her menopause. We know that 10% of women don't experience any symptoms, 10% will experience severe symptoms, and then the remaining 80% are somewhere in between. So, where to from here? If you've watched this presentation and you thought, okay, some of those symptoms resonate with me, maybe I need to see someone, what is the next step? It's really talking to your healthcare provider or your GP, your menopause doctor, someone who can support you through your journey. And I think some women may have had or have heard of friends who've had poor experiences with their GPs. And I think if you can go in from the beginning and say, I've done the symptom checker, I want to talk about menopause, these are my concerns, can you support me? And, GPs, there's a huge amount of training for GPs. There's more and more interest because we know that there's a demand for menopause care. And so I think starting with your GP is a really reasonable point. But if you, can't get in with your GP or you're struggling, whatever it is, there are plenty of doctors like myself who work in menopause clinics where that's all we do. The consult is all about menopause and treatment and how we support you through that. And, if you feel you need that, it's a great option as well. I think reaching out to other people is really important as well because every woman will go through menopause. Every woman's experience of menopause will be different, but if you can connect with people who are going through things that you're going through, it can be very supportive. And you may not feel comfortable talking to your friends or family about it, but there's an amazing Facebook menopause group, which a lot of women are on, where you can discuss things that you may not want to discuss with people you know, and just to have that support and know that you're not alone. And then, of course, finding mental health information. So whether that's with your psychotherapist, GP, the slide I found online, which is, mental health options. If you want to screenshot this, it's quite handy. So if you need to talk to someone, if you need more mental health support, I think this is a helpful tool. So finally, to wrap up, menopause is a change in a woman's life which can be accompanied by a lot of mental health symptoms, and whether that's mood symptoms as a result of the change in her hormones or mood symptoms as a result of her physical symptoms, it can be a really difficult time. Reach out to people who can help you. So whether that's your GP, your menopause doctor, friends, family, find people who can support you. Be kind to yourself, be kind to others, look out for other women who may be struggling. If you know that you've gone through it and you know that they need help, reach out to them because they'll really appreciate it. And if we're going down the treatment route, we've got great evidence for HRT. In patients who can't take it, antidepressants is a really good option, and CBT, there's a lot of data as our treatment or therapeutic modality. So that's menopause and mental health in a nutshell. I don't know if we had any questions who came through, if there's anyone in the audience who would like to ask any questions.
That's just while the questions are loading here, I just want to say, Dr. Genevieve, I found that very informative. I will be practicing my box breathing when we go home. And I just wanted to actually link as well, when you logged on today, you saw a leaflet that was actually co-produced by one of our colleagues, Andrea, in mental health. It was launched in Limerick last week, and it will be available. There's a link available. I'm sure it'll be up on Twitter for you to download. So it was very informative because I'm still waiting on questions coming through the webinar. But if there's anybody in the audience, we're open to questions.
I have two.
Great.
One with the private hat and one with the work hat. Oh no, I don't like that. With the private hat on, in your experience, do conditions like an underactive thyroid act up and influence mental health issues then in perimenopause or menopause? And is there any difficulty in taking HRT if you're on thyroid medication?
It can. So an underactive thyroid tends to present with, initially, if you are not on medication, kind of a slowing down of the metabolism. So you feel tired, you may be gaining weight, and definitely a low mood is accompanied with that. And so when there are changes in menopause or estrogen and progesterone, that can definitely have an impact on your thyroid as well. So if you're already on thyroid medication, it may need tweaking around that time. You may find that your thyroid symptoms exacerbate. It can be tricky because a lot of symptoms of perimenopause or menopause look like thyroid symptoms as well. So how do you determine which one is which? If you're on thyroid medication and you've been well controlled up until now, we would assume that it's menopause, treat your menopause. If you're still symptomatic, maybe we retest your thyroid. If you were not on thyroid medication, we maybe need to check it at that point. It's absolutely fine and safe to use HRT and thyroid medication alongside each other, provided that the estrogen is through the skin. So I didn't really mention that on HRT. You get different types of estrogen, which is oral estrogen and transdermal. Transdermal would be your patches and your gels. Oral would be a tablet like the contraceptive. Oral estrogen impacts your sex hormone binding globulin and your thyroid hormone binding globulin. So if you're on oral estrogen, it could then impact the functioning of your thyroid medication.
And would say a menopause specialist know about that? Say if someone were uncomfortable talking to their thyroid doctor about menopause, would the menopause specialist be aware of the interactions?
Yeah,
okay,
yeah.
Cool, thank you. And with my work hat on, I work in mental health services, so we would work with service users that have severe and enduring mental health conditions. And some of them obviously would be in that age where menopause may have already happened or they might be in perimenopause. Is there anything staff can do, for example, to pay attention in terms of symptoms if these service users might be able to communicate because they might have dementia or they may have had a stroke, but they would have mental health symptoms? And again, like with the thyroid thing, do we know what the difference is and how can we help people?
I think really it's to look out for changes in their baseline. So if you have a patient, a female patient with a mental health condition who's in her 40s and 50s, and you see maybe more irritability, more anxiety, a change in mood. You know, there will be accompanying physical symptoms as well. So the loss of periods would be obviously a red flag that this could be menopause. But also, are they vasomotor symptoms? Are they sweating more? It very much depends. You know, if there's a head injury, they may have autonomic dysfunction, and so they may not have the vasomotor symptoms. So it can be difficult, and especially in a patient who can't say to you, I feel X, Y, and Z. So I think it's important as people who are in a caring role for these individuals and as healthcare providers, it's really to look, what is there a change from their baseline?
And do these, say, mood stabilizers or antipsychotics, would they interact with the HRT or?
For most patients, transdermal estrogen doesn't interact with oral medication.
Cool.
Yeah.
Just while the mic is being passed around, there's some online. So there's a lot of thank yous, and the presentation has been very uplifting, but does evening primrose help?
Yes, it's very helpful for breast tenderness, which is a common symptom of perimenopause especially. It probably won't have a significant impact on any other symptoms. So a helpful add-on, it can be taken alongside other medications, but I wouldn't use it necessarily by itself.
And if you were to go down the HRT route, is there a recommended length of time to take HRT?
No, it's changed. So previously the guideline was you can take it for 5 years or up until the age of 60, and then you must stop. And now we know that it's much more individualized than that. You know, if a woman goes into an early menopause, she'll need to be on it for later. If a woman is in that what I mentioned earlier is that 10% of women will have severe symptoms. 10% of women will have ongoing symptoms. So for most women, their symptoms last 7 years. They go into postmenopause and symptoms improve. And in theory, at that point, we can stop their HRT. But if they have ongoing symptoms, we may need to keep them on HRT for longer. So really, it's an individualized approach to HRT, and every woman would be different. Exactly.
I think we have another one from the audience.
Hi, just on HRT, if you have a family history of breast cancer, does that mean that you wouldn't recommend taking it?
Not necessarily. It depends on who in your family had it, how many family members had it, their ages. But for most women, even if they have quite a significant family history, they could still use HRT. We would just need to be mindful of ongoing breast screening, breast examinations, and so on. But we have patients who, you know, say their mum had breast cancer in their 50s, and she's grown up thinking, okay, well, I can never go on HRT. And actually, she would be able to. Obviously, the decision is made between the patient, her, menopause doctor or a GP, and maybe her breast consultant as well if she has one. But for many women, even with family history, they can take HRT.
Yeah, I think, again, I'd just like to thank you. And I suppose I'd like to thank everybody for joining in today. And from a mental health point of view, as they say, that the little badges that are here, just do what you can do. Thank you again, Dr. Genevieve.
You're welcome. Thank you.